Good morning, everyone. My presentation is on large wooden intraorbital foreign body, a case report. There is no financial support and sponsorship, and I have no conflict of interest. Introduction. Intraorbital foreign bodies are a global phenomenon and occur with a frequency of 1 in 6 orbital injuries. However, intraorbital wooden foreign bodies are uncommon. Intraorbital wooden foreign bodies predominantly affects male population with a mean age from 18 to 25 years. These vegetative foreign bodies must be removed as it serves as a needles for orbital infection. And we report such a case of a large intact intraorbital wooden foreign body which was removed successfully and improvement seen in the ocular status of the patients. Case history. A 25-year Hindu male from Keonjhar, Odisha presented to our casualty on 15th March 2022 with a sustained wood penetrating injury in the right eye. He had a history of accidental fall from the tree on the same day. On examination, his GCS was 15 out of 15 and on ocular examination, his visual acuity was perception of light in the right eye and 6/9 in the left eye. There is restriction of extraocular movement in all direction in the right eye. On anterior segment examination of right eye, there is a mild proptosis along with congestion and chemosis. And there is a sealed corneal tear present with a corneal edema. Pupil was dilated and not reacting to light. The AC was maintained. And a large wooden foreign body located at the medial canthus, as we can see in this picture. Fundus examination was not possible in this case because of the hazy media. The CT scan of the orbit was done and air density was found in between medial wall of the orbit and globe. There was no intracranial or nasal cavity penetration and the globe was intact too. Coming to management, the patient was hospitalized immediately. Injection tetanus toxoid, intravenous antibiotic and analgesics along with moxifloxacin eye drop were administered. After neurological consultation, the case was planned for the exploration. After giving the peribulbar block, under all aseptic condition, with the help of artery forceps, the wooden piece was removed intact and the size of the foreign body was 8 into 3 centimeter. The wound area was clean and the gap was closed by retracting the globe medially with 6-0 vicryl suture. Intravenous ceftriaxone, diclofenac and pantoprazole along with oral fluconazole antibiotic with steroid eye ointment were given post-operatively. These are the images of the patient on pre-op, intra-op and post-operatively. And there is an image of the intact intraorbital wooden foreign body. Coming to the post-op status, on day 1, the wound was healthy, no discharge, chemosis and corneal edema subsided, the pupil was dilated and not reacting, and his vision was still perception of light. On day 3, there was mild congestion present, chemosis resolved fully, and the vision was perception of light. On the day 4, the patient was discharged with oral antibiotics, steroids, and topical eye drop and ointment. Coming to discussion, the retained wooden foreign body may lead to complications like prolonged suppuration, cellulitis, abscess formation, panophthalmitis, and extraocular muscle damage. As there is no definite imaging studies, CT scan is usually performed in orbital trauma cases where foreign body penetration is suspected. After excluding the possibility of the metal foreign body, MRI can be performed. Surgical removal of the wooden foreign body requires extreme caution and utmost care must be taken to prevent fragmentation of the wooden pieces during extractions. To conclude, 90% of the orbital injury is preventable, so prevention is better than cure. And implementing appropriate imaging modalities for diagnosis and care for surgical removal of foreign body is critical to minimize the complication and a good post-operative outcomes. These are my references. Thank you.
Thank you. What are the steps you recommend for the prevention of these injuries?
First, we need to correct the refractive error. As in my case, the patient is having 6/9 in one eye, so that is the first thing. The second is we can ask the patient to wear glasses while working to protect the eye.